Good evening, everybody, and welcome to this Prostate Cancer UK webinar titled Sexual Side Effects and Your Wellbeing After Prostate Cancer. I'm Jonathan Kay. I'm the Health Information Service Lead at Prostate Cancer UK, and I'll be hosting for this evening. Before we get going properly, I just need to go through a little bit of housekeeping. So firstly, hopefully, as you can all see, this is a Zoom webinar. It's a bit different to a Zoom meeting in that throughout the session this evening, you'll only be able to see myself and the panelists and the slides that we're presenting. Your cameras are all off and your microphones have been muted. So feel free to chat amongst yourselves. Don't worry about any background noises or anything like that. You can't disrupt us. As we're going through, if you've got any questions for the panel, please use the Q&A function to submit them. I'm very glad that we've got Sophie and Grace from our specialist nurses team here at Prostate Cancer UK on hand to respond to some of these questions in the chat. We'll also have a more dedicated Q&A session towards the end where we can go through some of the questions in a little bit more detail. So just as a warning, please don't include any personal health information within your questions because unfortunately, we won't be able to answer them if you include them on this. And please also note that only the questions that the nurses answer in the background, you'll be able to see answers for within the relevant section. We're sorry if we don't get to all of your questions this evening. If you're left with any urgent questions, remember the specialist nurse services are available Monday to Friday, 9 till 5. We'll also aim to collate any unanswered questions throughout the webinar and answer them in a summary email, which will come out in the coming days, along with a recording of the webinar. And please note that everything in this webinar is for general information purposes to help you understand and navigate your situation better. It doesn't constitute medical advice. Really importantly, we're going to be covering some issues tonight that some of you might find challenging or even distressing. If you find it difficult at any point to listen to, don't worry, feel free to step away and come back to it at a time when you're ready. Like I said, we'll be circulating a recording of the webinar afterwards, so you can always pick up where you left off at a later date. So I'm delighted to be joined this evening by our wonderful panel, which encompasses clinical experts as well as a man with lived experience. And I'm just going to invite them up to introduce themselves now. So if you'd just like to introduce yourself, Lisa.
Hi, I'm Lisa. I'm one of the specialist nurses at Prostate Cancer UK. I'm also one of the nurses on the sexual support service. I've been at Prostate Cancer UK this time around for just over 3 years.
Thank you. And I'll pass you over to Isabel now.
Hi, I'm Isabel White. I'm a psychosexual therapist, but also a cancer nurse by background, and I work part-time for the Royal Marsden Hospital, offering psychosexual therapy to people who've been through cancer diagnosis and treatment and are experiencing sexual difficulties after their cancer treatment.
Great, thank you. And then finally, pass you over to Steve and Stella.
Yeah, so I'm Steve, I'm 54 and I was diagnosed with prostate cancer just over 3 years ago.
And hi, I'm Stella and I'm Steve's wife.
Great, thank you. Right, so I'll pass you over to Lisa in a few minutes to get the session going. But before that, I'd just like to flash up a quick poll for you all to take part in so we can get a better understanding of our audience today. So as it says, we'd love to know more about our audience today. Please, can you select any of the below that apply to you? And don't worry, this is completely anonymous. It's just for us to understand who we've got here. So I'll leave this open for a little while. That's great. We've had well over 100 of you respond so far. Okay, I'll end that there. So as expected, obviously a lot of you are here because you've been diagnosed with prostate cancer and you're interested in the support and information that we're offering tonight, but it's also good to see that we've got some people in the room that I'm assuming are partners of men with prostate cancer here to get support and information as well. Okay, so during this webinar, we'll hear about some of the challenges that can occur due to the side effects of prostate cancer treatment or living with prostate cancer itself. We'll focus on how they could impact your mental well-being, your sex life, and your relationship with your partner. We'll also talk about some of the support options you might want to explore, including psychosexual therapy. You'll also hear about how men like yourself have coped with these challenges as part of their own prostate cancer journey. I'm now going to pass you over to our clinical nurse specialist, Lisa, who will give you an introduction to the sexual side effects of prostate cancer treatment. So Lisa, over to you.
Thanks, Jonathan. Hi, everyone. So just the word cancer alone will conjure up a variety of emotions, including previous experiences. Add into that the mix, you or a loved one being diagnosed, going through treatment, and then living with regular PSA blood testing, and worry that the cancer might not have gone, and having to live with the side effects that treatment may have caused. Is it any wonder men have problems with their erections? The World Health Organization state that sexual health is fundamental to the overall health and well-being of individuals, couples, and families, and to the social and economic development of communities and countries. Sexual health, when viewed affirmatively, requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. The ability of men and women to achieve sexual health and well-being depends on their access to comprehensive, good quality information about sex and sexuality, knowledge about the risks they may face and their vulnerability to adverse consequences of unprotected sexual activity, ability to access sexual health care, living in an environment that affirms and promotes sexual health. Basically, round it up, men getting regular erections increases their emotional well-being. Every possible treatment for prostate cancer can cause sexual side effects. Those side effects can include not being able to get an erection or only partial erection, not wanting sex, having a decreased libido, not feeling desirable, not feeling like a man should, or not being able to perform, getting a shorter penis, changes to their ejaculation. The orgasm may feel different or unable to. Infertility, bodily changes such as man boobs and leaking urine. Other causes can include heart conditions, diabetes, smoking, recreational drug use, drinking alcohol, obesity, prescribed medications, for example, antidepressants, blood pressure medications, and hormone therapy. So it might help to understand firstly how all the magic happens. It all starts in the brain with a thought, feeling, smell, something heard or seen. The brain sends messages to the blood vessels in the penis through the nerves. A chemical process occurs which allows the arteries to relax and open, which lets blood flow in, and the veins close, preventing the blood from leaving. Just give you a little warning, I'm just about to show a medical image, so look away if you need to. The blood fills the spongy tissue, which is called the corpora cavernosa, which you can see here, and a gate-like system keeps the blood in. The penis gets bigger and becomes erect. Prostate cancer treatments can damage or remove these nerves, making the communication from the brain to penis difficult or non-existent. Prior to prostate cancer treatment, men get between 3 and 5 erections overnight whilst they're asleep. This is nature's way of keeping the blood circulating. I am a bit of a queen with an allergy, so I apologise, but this is how some people might feel. So if you break your arm, for example, and it goes in plaster cast, once that plaster cast comes off, then the arm is all withered, it's wrinkly, it's dry, the skin isn't very good quality. That's exactly the same with the penis. If the penis isn't getting regular blood circulation, it's similar to having it in a plaster cast. So therefore, without regular erections, the penis becomes shorter and less healthy. Men and their partners who call our helpline tell us they feel alone, they're worried about intimacy, they cannot orgasm, or it feels different. Their penis has shrunk, they miss how sex was before, there's no spontaneity. They have a reduced quality of life for both themselves and their partners. This can be associated with anxiety, depression, loss of self-esteem, and confidence. Their partners may express feelings of rejection, unattractiveness, or even guilt. All of this can include feelings of loss, grief, and missing how the sex was before diagnosis. Our sexual support service consists of 6 nurses who are experienced. Our aim is to give men and their partners time to talk openly about the changes to their sexuality and any sexual difficulties since prostate cancer treatment. We aim to help people understand their own or their partner's options and adjustments for a fulfilling sexual relationship. So, for example, we may well talk about how to have sex in different ways, maybe not having penetrative sex or using sex toys. We aim to discuss treatments for erectile dysfunction, how to use them, and the impact on relationships. We explore potential solutions to these issues and give guidance tailored to the service user's needs. We also can signpost to other services, for example, psychosexual counselling. Just one thing to note, that the nurses on the sexual support service are not counsellors. You can access our service by calling the helpline or filling in the online form on our website, which a link will be posted shortly for you. We need to ask sensitive and very personal questions to work out how best to help. We will encourage you to be open and honest and talk freely. Questions we may ask: what was your sex life like before diagnosis? Have you got a partner? Lots of men that we speak to haven't got a partner, and that's absolutely fine. That does not matter. We also talk to men who are in same-sex relationships or straight. We may well talk about if you can get an erection with or without medication. Do you have morning erections? Is the desire there? Is the libido there? And what treatments have you tried? We will then go through some suggestions, examples of which will include erectile dysfunction medications or treatments. We may suggest masturbation. We may even suggest sex toys. We can also signpost you to psychosexual therapy, counselling, or couples therapy.
Thank you very much, Lisa. That's a really good introduction to some of the topics we'll be talking about in a bit more detail today. And just as a reminder to everybody listening, if you have any questions, feel free to drop them in the chat and our nurses will be able to pick them up. So moving on now, we hear a lot of feedback from men that they really value hearing the stories of other men that have gone through similar experiences themselves on their prostate cancer journeys. And that's why I'm now delighted to be able to introduce our guest, Steve, and his wife, Stella, who have kindly agreed to share his story with us. Just as a bit of background, after Stella encouraged Steve to visit his GP, Steve discovered, unfortunately, that he had been diagnosed with prostate cancer in December 2021. Luckily, he had successful surgery to remove his prostate following consultation with his medical team, but unfortunately developed very challenging side effects, which included incontinence and erectile dysfunction. To start things off, both of you, welcome. How are you both feeling today?
Yeah,
Both good?
Good,
Yeah,
thanks.
good.
Yeah.
Excellent. Okay, first question then, to start things off. Steve, could you start by telling us a little bit more detail about some of these side effects that impacted on your ability to have sex and the experiences you went through post-surgery?
Yeah, sure. I mean, when I was first diagnosed, the first thing I think is important to say is we were given lots of information from Prostate Cancer UK. So the information was there. However, not taking it all in at the time, because I think, as you mentioned earlier, is the first thing is being diagnosed with cancer is enough for anyone to deal with. I didn't actually think too much about the erectile dysfunction, to be honest. It didn't really occur to me. I kind of thought in the back of my head, I'm going to be okay, which was naive of me. And I'm quite open with this. And with Stella, I did say to Stella when we did read it and we spoke about the erectile dysfunction, I did say to Stella, look, you know, you're 51. If you want to go off and find someone else, I totally understand. And it wasn't me pushing Stella away. It was a case of I wanted her to have a normal sex life, knowing that I could have complications, and that wasn't the case. But yeah, the side effects are As a man, they're pretty deafening in your ears, and it bangs a lot on your heart and your mental health. I suffered greatly with going down a rabbit hole that I didn't need to go down. I didn't want to speak to friends and family. Um, and I think it was really hard knowing that for the rest of my days, everything to do with an erection or having sex is always going to be mechanical. And that took my brain to a different place I didn't want to go. I don't want to sugarcoat it and say it's always going to, it's not a nice thing. Some people may be different. I had lots of information from Prostate Cancer UK specialist nurse when I did phone them because I didn't know where to go. We were very lucky for where we are in the southeast of Kent that we have good support services here. So there was lots of people in the hospital that I could ask, and I had lots of meetings, and they said, we can go with a pump, we can try medication, we can try this and different things. But it was tough going, and it still is to this day.
Yeah, I imagine that sounds incredibly challenging. And I suppose my question then to you then, Stella, is how did that impact on your relationship? There's obviously some very challenging things that Steve's brought up, that just that idea of, of him saying effectively you go off and find somebody else must have been something you never expected to be in your lifetime. So how
No,
how did that
I
impact
mean,
you? And
yeah, I mean, when we got married, we made our marriage vows in sickness and in health. And so, when Steve raised that subject, I was heartbroken because I did understand how he felt, and I understood why he was saying it. But he hasn't changed as a person. This is a journey that we've been on together. And yes, it was a shock when he was diagnosed. And as Steve said, we knew of the complications, but we didn't really focus on that at the time. What was important to me was that Steve would recover and he'd have his surgery and he would be here. So we kind of parked those conversations until he was well through his recovery. But I think the major adjustment for me was Steve has always been the strong person in our relationship. So for him to suddenly be doubting himself and not knowing how to fix something was quite a challenge for me to get my head around. But we worked together, we talked a lot. We lent on the resources that were available to us, and we are aware that those services are not available across all regions. We were very, very lucky, but we lent into them, and just through continuously talking to external services as well as each other is how we've just managed to work our way through it.
right, I mean, you've touched on some of the kind of support you received from our charity, and it's great to hear that you found the information we produce and our nurses helpful. Was there any other support that either you got individually or as a couple from the NHS, or was there anything else that added to that?
We did get we had some therapy sessions with Macmillan. That was offered to us, and we thought, yeah, we'll actually take it. But it wasn't for us, because I felt that they were painting a very doomed picture about our future, and it really kind of scared us a little bit, because the way that they were explaining things was saying your life was a nice line beforehand, and now it's just dropped. You're in the pit. And I thought, wow, I really don't want to hear this at the moment. But that's the only one. And apart from the erectile dysfunction clinic that was at the hospital, they were the only two that we actually visited.
Okay, great. I'm unfortunate. I'm sorry rather to hear that, the support you got from Macmillan wasn't what you needed, but I think it's, from our point of view as a charity, I think it's important to highlight that, there are plenty of other charities among, other than just ourselves, that are able to support people like you. So I'd always encourage people to, to look for a wide range of resources to try and find the support that is suitable for you. Okay. I suppose I can give this question to both of you kind of individually, but I'll start with you, Steve. But what advice would you give to another man or a couple going through the similar situation to what you've been through?
A real simple one: talk. talk and talk, whether it be to your friends. If you're that open, I think when you've been diagnosed with prostate cancer, your inhibitions just go completely out the window. So I will talk about anything from erections to masturbation to erectile dysfunction. You have to be like that as a man. And a typical man can be quite reserved. They don't want to talk about their feelings as well. But one thing regarding prostate cancer, it doesn't hide anything from you. You've got to be quite open. Talk to friends and family. If you don't want to talk to friends and family, you've got to reach out to Prostate Cancer UK. You can't do this on your own, and I'm living proof that you cannot do it. I felt worthless. I didn't feel like I was a man. I felt completely changed. I still do now to a certain extent, but I accept it. That's the way it is. But I couldn't do it on my own. If it wasn't for Stella, she was my rock as well. And we had to lean on each other. And eventually, it's a case for any men the men that are listening and the women that are listening with their brothers or husbands and partners, get checked, talk and reach out to people.
Great. That's incredibly sound advice. Stella, have you got any pearls of wisdom that you'd like to add, to give to the audience? Not putting you on the spot or anything.
No, that's fine. I think it's important to recognise that prostate cancer is something that has happened to you. It doesn't have to define you, and it doesn't have to define your relationship afterwards. Personally, we've gone on a different journey. Our sex life is different, but it's not. We found a way to discover new ways of being intimate. So we sort of approached it as an opportunity to get to know each other again. And it doesn't have to be all doom and gloom, and you don't have to just accept that that's the situation that you're in and nothing can be done about it. So with Steve, his treatment started with being prescribed Viagra. That didn't agree with him. So we went back and he was given another option of using a pump. So it's just something that we've accepted. A spontaneous erection, Steve can't achieve anymore. So we just play around and we find other ways of being intimate and just enjoying our personal time together.
Great, thank you. So would you say that maybe this is something that I hear a lot of men talk about, kind of a new normal,
Yes.
your life is not what it was pre your cancer diagnosis, and it never will be. But do you feel like you have overcome all of these barriers now? Do you feel like you are now comfortable, happy, and kind of over these issues?
Yeah, absolutely. The new normal is a really important way of putting it. But then your life is never the same after a diagnosis of cancer anyway. So we just packed it up into the same bag and said, okay, well, this is our new normal. The new normal is regular PSA tests. Yeah. We do get anxious round about the time, but Steve has just gone from 3 months to every 6 months, which we're taking as a real positive. But yeah, creating a new normal, a new happy normal for yourself, and only you can define what that is going to be.
Yep.
Great, thank you. I think this conversation has been really helpful. I'm sure all the audience listening will have taken a lot of help, support, and advice from what you've said. So I just want to say thank you so much for sharing your story. It's not an easy thing to talk about, to just go into some intimate details with a complete stranger, an audience like this. So yeah. We really appreciate it. So thank you very much. And again, another reminder to everybody, if you've got any questions specifically for Steve and Stella, they'll be hanging around for the Q&A session at the end, and I'm sure they'll be happy to answer any questions that you have. Okay, so now moving on, I want to introduce Dr. Isabel White again. Just waiting for the slides to load up. So as you've already heard, she's a psychosexual therapist at the Royal Marsden, and she's our guest speaker for the evening. She's going to give us an introduction to psychosexual therapy and how it can help men with prostate cancer to come to terms with the sexual side effects that they experience. So I'll hand you over to Dr. Isabel White now.
Thanks, Jonathan. Thanks for that kind introduction. Please, all of you, just think of me as Isabel. I'm not comfortable with the kind of full title. It always makes me feel quite strange. But anyway, really lovely to be here and to be with all of you. I guess I really want to help people understand more about what psychosexual therapy or psychosexual counselling might be able to offer people who've experienced cancer and cancer treatment. And in this instance, obviously, prostate cancer is our focus. There are often a range of effects that having gone through prostate cancer treatment can have on your sense of sexual identity, your sense of sexual self, your sexual confidence, and how you actually relate to each other as a couple if you're in a relationship currently, or indeed how you anticipate relating to a new partner or another person in your life from a sexual perspective if you're not in a current relationship, but you aspire perhaps to have one or more relationships going forward. What I hear a lot from men that I work with is that they feel that the way they've been defining themselves as a man changes, and they begin to question whether or not that's a helpful definition, or whether they need to think again about what it means to be a man and what it means in terms of their masculinity. A lot of men will feel that their sexual confidence has been adversely affected. For some individuals, it may mean that the role that they had in the relationship sexually has actually changed. Particularly, I think, in heterosexual relationships, it's quite common that the man is the main initiator of sex. And it's often the man's appetite for sex that actually sets the, if you like, the frequency of how often sex happens for a couple. How often they'll have sex in any given week or any given month is often determined by the man's sexual appetite more than perhaps it's determined by a female partner's appetite for sex. In a same-sex partnership, again, it may be that one or other of those individuals, again, has more of a sexual appetite and sets, again, the frequency. And if you're then faced with a cancer diagnosis and the impact that that treatment then has on your sexual function and on your sense of sexual well-being, that may mean that actually you either don't have the same appetite for sex, or indeed you may actively avoid being sexual because it's quite confronting and quite distressing to be in that scenario. So there may be a reluctance to initiate sex with your partner, not because you've lost any sexual interest in that person, but because your own sexual confidence has taken quite a significant impact, if you like, from going through cancer diagnosis and treatment. It may be that not just intercourse stops, but actually most couples will say to me, actually, we've stopped being physically affectionate towards each other in any other way. And the reason for doing that is because there's a real worry that if you start being sexually affectionate towards your partner, that your partner will expect that to then lead on to more full sexual expression. And if you either aren't ready for that, or you aren't able to functionally offer that to your partner anymore, or you need to use medications or aids to help with that, then again, you may feel that actually, again, it's too confronting and it's happening without you feeling that you're in control of the situation. So then there's a tendency to withdraw and actually then reduce all types of affectionate contact with a partner. And of course, for the partner, that then feels, again, quite lonely and can sometimes cause a strain or a difficulty in the relationship. So there may well be avoidance of all physical contact, and that can be, again, misinterpreted by both of you in terms of what that means for the relationship. So there might be an increase in emotional distance between you, and again, there might be some relationship strain. Next slide, please. So what is psychosexual therapy, and how might it be able to help with some of those challenges? Well, really thinking about psychosexual therapy, it's what we would refer to as a brief therapy. In other words, there's not the intention that when you go to see a psychosexual therapist that you'll be in therapy for a very, very long time. Most of us will work on a 6 or a 10 session basis where we are actually working actively with an individual or with a couple to actually help them explore what are the sexual challenges that they're facing and what are the strategies that we might be able to help them with that actually might help them overcome some of those challenges. We use what is referred to as a cognitive behavioral approach. So we're looking at the relationship between what our thoughts are, what emotions are created by those thoughts, and then what those thoughts and those emotions create in terms of a behavioral change. And in the previous slide, I was making reference to some behavioral changes like withdrawing from all physical contact. That would be a behavioral change based on difficult emotions like feeling embarrassed or feeling that you'd lost sexual confidence. And that would again be also linked to thoughts around, well, if I can't get an erection, then I can't actually create sexual enjoyment for my partner, or I don't feel like a man in this situation anymore. When we work with individuals or couples, most psychosexual therapists will work with you even if you're not in a current relationship, or if your partner, for whatever reasons, cannot join you, for therapy. We're very happy to work with individuals, but we do prefer to work with couples where possible, because sometimes that means that it's easier for you both to be on the same page in terms of what the therapist is trying to encourage you to focus on, and it doesn't then rely solely on the man in the situation who's got the diagnosis to actually be the person trying to communicate that with their partner while also coping with their own emotions and their own challenges. And what we always do is we combine what we would call biomedical strategies. So are things like pumps, injection therapy, and tablets, for example, which we'll come on to in a bit more detail, with psychosexual counselling. So it's not just a talking therapy, it very much integrates three key elements. So we've got the physical function. So in other words, what has your treatment and your diagnosis done from a hormone point of view, from a blood vessel point of view, from a nerve function perspective? And are there any other existing physical illnesses, some of which Lisa referred to, such as high blood pressure or diabetes, which might have already made erectile function more vulnerable prior to the prostate cancer treatment? And we're also looking at what medications you're on, again, to identify whether some of those medications may need to be thought about or be adjusted, perhaps, because they may be contributing to the erection difficulties. We look at people's emotional responses to these changes that might be happening for the individual and for the couple. And we're looking particularly at people developing high levels of anxiety, which can also make erection difficulties worse, or indeed people who are becoming quite low in mood. Again, those can exacerbate erection difficulties as well as any physical cause. And then obviously knowing about other mental health challenges that that person may be living with as well, again, helps us understand them as a person and how to work most effectively with them. And then last but by no means least, whether you're in a couple relationship currently or you're aspiring to be in a couple relationship going forward, and that couple relationship doesn't have to be long-standing, it might be a new partner, it might be casual partners, or it might be multiple partners. All of those are acceptable relationship contexts for us to think about the couple interaction, the interaction between more than one person. And here again, we'll look at how couples might then interact with each other in ways that are either helpful to their circumstances or less helpful, such as blaming each other for difficulties, bringing up things from the past that maybe can't be changed, denying that there's a challenge or a problem, and maybe not wishing to even seek help for it in the first place, and can cause a source of strain and difficulty for couples, or indeed anger and relationship strain. Next slide, please. So here are some biomedical interventions for erection difficulties, some of which Lisa made mention of in her presentation. We would always tend to try and start off with oral medication. But one thing that's really important to be aware is that there are certain circumstances where oral medication may be less likely to work effectively. And those circumstances are particularly where someone hasn't had, if they've had surgery, someone hasn't had what we call nerve sparing or partial nerve sparing surgery. So if the nerves have been significantly damaged, it is less likely, it's not impossible, but it's less likely that oral tablets alone will actually work. Likewise, if someone is currently receiving androgen deprivation therapy or hormone therapy to suppress their testosterone levels, again, under those circumstances, some men find that the tablets do still work, but a larger proportion of men may find that the tablets don't have the same impact. And so we may need to then think about different types of interventions that can work more effectively under those circumstances. But we will generally use one of those 4 different medications. The most commonly used and the most well known, of course, are Viagra, or sildenafil is its pharmaceutical name, or Cialis or tadalafil, which again is a very similar drug, as are avanafil or Spedra and Levitra or vardenafil. They're used less frequently, but they work in a very similar way. And all of these are what we call vasoactive drugs. So their sole purpose is to bring extra blood into the penile arteries that Lisa was telling you about, to actually try and swell up the corpus cavernosum with blood and then create rigidity within the penis. If we've tried those drugs on approximately 8 separate occasions with maximum stimulation and optimizing the dose and making sure it's the right dose for the person, if it's still not working, it may be possible to switch to a different drug and you may get a better effect from using a different drug. But if you tried oral drugs significantly and you've tested those out either through your GP or through an erectile dysfunction service, for example, or your urologist, then you may then be advised to move on to a different level of treatment. And that is usually something like alprostadil, which is a drug that you can deliver into the penis directly, and therefore it doesn't require the same nerve function to send signals to the penis. And also it can operate in the absence of testosterone. So if you've had your testosterone suppressed because you're on androgen deprivation therapy or hormone therapy, then you can use injection therapy or alprostadil administered as a pellet or as a gel to actually directly apply it into the penis, and by doing that, bring extra blood into the penile tissues. Generally speaking, these 3 treatments, the Muse, which is a pellet, the Vitaros, which is a gel, and the cavernosal injection, either alprostadil, which comes under different trade names, such as Caverject, for example, or Invicor, which is a combination of 2 different drugs, but they act together to bring extra blood into the penile arteries again. These are usually prescribed and delivered through an erectile dysfunction clinic. So you're then taught how to actually administer those medications yourself at home. Many men are actually given a vacuum device or a vacuum erection device or a vacuum pump, it's sometimes called. Again, there are different styles of these pumps, and they can be used in 2 key ways. One is they can be used as a form of physiotherapy, if you like, for the penis by stretching the penile tissues, bringing extra blood into the penile tissues and creating rigidity. And then the vacuum can be released, and then the penis can be allowed to go back to its normal flaccid state again. But by stretching the penis, it helps maintain the penile length. It also helps reduce the likelihood of a curvature developing in the penis, if that may, because that can sometimes occur after prostate surgery. And also it actually helps reduce scar tissue formation in the tissue, in the tissues of the penis. So it can be used very much to, if you like, preserve the penile health to a large extent. And some men and couples will be happy to also use it to actually create an erection that they can use to make love. And in that instance, there's actually a small constriction ring that's mounted onto a ridge at the edge of, or the end or opening of the pump. And then when the erection has been created by creating the vacuum, before the vacuum is released, that pump ring, if you like, is pulled down onto the base of the penis, and it goes round, if you like, the base of the penis like an elastic band around the base of a finger. And that traps the blood in the penis, and that can be left safely for up to 30 minutes so that you can then carry on and make love using that erect penis. If all of these things don't work, and also if the couple feel that actually being able to get and keep an erection is a really important part of their lovemaking and the man's sense of sexual identity, if they don't work, then it is possible to have an internal penile implant or prosthesis inserted. It's a surgical operation, and there are two main types of prostheses. The one that's shown here is called an inflatable device, where there's a little reservoir that's actually implanted under the skin over your pubic area, and it's attached to some very small little tubes, which to these two long cylinders, which are placed up either side of the urethra in the penis. And a little valve that's actually implanted inside the scrotum, which you can then feel, and then you can use the valve to actually open it and pump the fluid into the cylinders, which then creates an erection. And then, having had intercourse, you can then depress the little valve again in the scrotum, and that allows the fluid to flow out again, and the erection goes down. Penile implants are usually implanted either by urologists or andrologists, and those services can be accessed through your clinical treatment team, or indeed through your general practitioner. But as I say, usually people will prefer you to try other types of intervention first, and before resorting to a surgical implant as a solution. Next slide, please. In a way, thinking about the way in which sexual health or sexual support services are offered, it's easy to think of them as three different key levels. And this is based on a model called the Plisset model. And that first level, that self-care support and self-management, which many of you are obviously already, I imagine, engaged in, is you being able to reach out and find the different sources of support, such as Prostate Cancer UK and other websites that can offer advice and guidance in terms of erectile dysfunction. So it's looking at webcasts, it's looking at podcasts, it's looking at what specialist products and support might be available. It might be thinking about buying lubricants, and particularly if the female partner is, for example, of a post or perimenopausal stage in her life, and maybe is finding that there's some vaginal dryness, and where the strength of erection is not perhaps strong enough to be able to penetrate under those circumstances, then using a lube might well actually make it easier to have penetration and for the erection to be maintained. Also things like sexual lifestyle guidance and gender identity guidance might be relevant here as well, along with obviously things like safe sex and contraceptive information, if particularly if you're not in a monogamous situation and you might be having casual sexual partners or more than one sexual partner in your life. At level 2, we're looking at specific suggestions. So here it would be advice on different types of erectile dysfunction medications, vacuum devices, which we've just talked about, all of these, and what we call psychoeducation. So giving you information about the optimal type of interventions that might suit your particular circumstances and your sexual lifestyle. And that might also include some advice about changes in sexual positions to help, use of certain sexual devices, such as, for example, using a hollow strap-on to actually have penetrative sex, if that's something that's acceptable to both of you, using cock rings to actually help retain an erection, which we can talk about again, instead of using just the rings that come along with the vacuum pumps. You can actually buy, sometimes it's referred to as an erection lasso, but the idea is it's got a little slide valve that allows you to tighten it to the level of tightness that you need, and that can help retain an erection. Especially if, for example, you're able to get an erection, but during intercourse it begins to fade and it gets softer, then being able to use an erection cock ring or loop, that can allow you to retain the erection until you've finished having intercourse. And then the top level, level 3, is really the level that comes to psychosexual counselling or psychosexual therapists. And here we're looking at people who are experiencing real emotional challenges and perhaps have other physical or emotional conditions alongside their prostate cancer. Or perhaps they're having relationship challenges because of the strain and the difficulties that the prostate cancer treatment has brought to them. Or they may be people who need specific help with, again, their sexual lifestyle and sexual or gender identity challenges. So those are the individuals who are more likely to have a need for psychosexual therapy. Next slide, please. If you're looking for different sources of help, these are just some organisations in addition to PCUK that you can think about accessing. If you're somebody who identifies as being gay or bisexual, or you're someone who has a non-binary identity, or you're gender fluid, or indeed if you're a trans individual, you may want to access the likes of Outpatients, which is a nationwide charity that really helps individuals who identify as coming from either a sexual or a gender minority background. And they work very closely with other organisations to help individuals reattain the kind of sexual life and sexual identity and confidence that they want to have. Movember and True North, they are also another charity that are very involved in prostate cancer support. They have a very good website, and they have information around sex and intimacy after prostate cancer on their website, in addition to what you'll find on Prostate Cancer UK. Sex with Cancer is a patient-led website which was established by two younger adults who both were treated for cancer, not prostate cancer, but breast cancer in one instance and testicular cancer in another. And they set up a website which is working in partnership with a sexual product website called Shush, which provides a whole range of both male and female sexual toys and products, which they can give really good advice about, which can help with sexual well-being and sexual experimentation. And then if you are looking for a sex therapist and it's not easily available to you through the NHS where you live, you can go on to the College of Sex and Relationship Therapists website, and COSRIT has a page which is called Find a Therapist. So you can put in your postcode, and then you'll be able to find out people who are working in your locality or within easy travel distance of where you live. Likewise, you can also go to Relate by finding out what your local Relate centre, where it's based. And again, many Relate therapists, as well as being couple and relationship therapists, are also psychosexual therapists. So again, they can help with psychosexual counselling and therapy. Next page, please. What are the things, though, that you can also do for yourselves? You know, again, thinking about that kind of self-care, self-management approach. And I think in terms of thinking about it from a psychosexual therapy point of view, first of all, I think one of the things that can be really, really helpful is when partners actually share responsibility for initiating sex, even if that has previously been the case, that it's been mainly the man in the relationship, or one of if it's a same-sex partnership, one particular individual was always the one who tended to initiate sexual behavior together or sexual encounters together. Because by sharing that responsibility as a partner with the person who's been treated for prostate cancer, you're taking a lot of the pressure away from them, and you're showing that this is truly a partnership where both of you are actually taking responsibility for being sexually intimate, for being erotic and being sensual together. And there's a key focus here on sensuality and intimacy. So it's not just about being able to have intercourse alone, although of course that is very relevant and important for many individuals and many couples, but it's also about how can we be sensual and intimate and erotic together to actually try and regain that side of the way in which we relate to each other, which is more than intercourse and much broader than intercourse. It might involve the use of sex toys. It might involve the use of erectile aids. It might need to involve actually making sex a priority, whereas before it happened quite spontaneously, quite naturally, but now there needs to be some thought and some planning goes into being sexual together. So under those circumstances, you might want to actually put date nights in the diary and say, well, you know, we're going to make sure that we've got extra time, we've got privacy, we're not going to be interrupted, because we need time to actually take our time and actually enjoy and get ready to be sensual and erotic together, rather than feeling that it needs to be rushed or hurried, or the fear of being interrupted, you know, when you're actually trying to be sexually intimate. And certainly what I often hear couples say is that it's really helpful. Again, it goes back to what we heard earlier, that it's really helpful to maintain good communication and use gentle amount of humor, not using humor to avoid talking about sensitive issues, but using humor to perhaps lighten things a little bit, and actually bring you emotionally closer together. But certainly it's really important to maintain all the other types of affection expression that you have, whether that's kissing, whether that's hugging, whether that's touching each other, whether it may be, you know, masturbating each other, for example. So things that may not always require an erect penis to be part of the agenda, and thinking of it very much like a buffet. You know, what can we actually create together to give and receive sexual pleasure, and actually select from that what we actually want to try on that occasion. And it's very much important to engage sexually with each other without waiting for your desire to spontaneously be there, or to wait for physical arousal to happen, because sometimes it can happen the other way around. That you know, our couple were saying there about, you know, we play around, and by playing around you create that relaxation in the mind, and then the mind and the body can work much more effectively together. And yes, you can take medication, you can have taken an injection, or you can have had an oral medication or a tablet beforehand, but again, that foreplay and that kind of sensual erotic play together helps you relax and get in the right mindset, which means then the powerful use of your mind is then also helping with the actual sexual response as well. And it is important to be open to perhaps some new sexual experiences that you may not have tried before. So, for example, you may be a man who's never thought of using a vibrator on your penis. Maybe your female partner's used a vibrator, but you would never think of using it on yourself. But actually, vibratory stimulation can also help with arousal, and can actually help bring extra blood into the penis. So can be a really useful, that's just one example of, you know, trying things that are perhaps new or different for you, to actually see whether or not that amplifies your sexual response. And for a lot of couples, it's about redefining what they mean by sexual pleasure. You know, it's thinking about the whole range of behaviors that you can engage in as an individual and as a couple, to actually enjoy giving and receiving pleasure using each other's bodies in different ways. So certainly you should expect sex to be different after prostate cancer treatment, but not always worse. Next slide, please. I think that's me finished, and I'm going to hand back now to Jonathan, I believe, or to Lisa. Oh, it's Lisa.
It's to me, but thank you, Isabel. Thank you so
You're
much
welcome.
for a really insightful talk. I'm sure our audience will have taken an awful lot from that talk. I think the one thing that I've really taken away from it, and I took this away from some of the initial conversations we were having when we were planning this webinar, it's the importance of dealing with both the physical and the mental aspects of these conditions. If you just treat the physical aspects, you're not going to have as much of an effect than if you also, you know, you continue talking to your partner or to your therapist, so you can really get to the bottom of those problems. That's when you see real benefits. And I think it's really important to stress that point to everybody on the call today. So thank you very much. I'm now going to just hand you over to Lisa, who's just going to talk through some of the resources that we produce at the charity that you may find useful. Lisa, over to you.
Thanks, Jonathan. So I mentioned previously before, so if you go onto our website, prostatecancer.org, then you can see our services that the specialist nurses provide. You can also call our helpline. We're open Monday to Friday, 9 till 5, apart from a Wednesday when we open at 10. We also have an answer phone facility. So if you can't get through, if we're busy, for example, please leave your name and phone number and we will get back to you. You can also go on the website and download or order our publications. We have publications on all aspects of prostate cancer, and you can easily search on the website. We have a wellbeing hub. Again, you can search for that on the website. We have one-to-one peer support. So we have a group of trained volunteers who've already been down a treatment route. So if you wanted to speak to a man who's had surgery and then trouble with their erections, we can put you in touch with a man. Also, we have partners as well, and we also have gaming. So you can call us, or there is a form online. If again you pop into the search peer support, you'll get the form up. We also have our online community, and that's where people, like-minded people, can post questions. It's free to join. You just need to create a username and password, and then you can post questions or reply to others. And it's a good way of chatting with like-minded people. Thanks, Jonathan.
Thank you. So that comes to the end of our presentations, and we're now going to move it into the Q&A session. So I'm going to invite the rest of the panel back, and we're going to go through some of the questions. We've had a lot of them submitted already, so thank you so much for the people that have already submitted the questions. You can continue to submit them, but as I said, we've had a lot of them already submitted. So if we don't manage to get to them, you can either contact the nurses, and we'll have those details up before the end of the webinar. But also, like I said before, we'll be circulating some answers to some of those questions in the coming days via email. So to start things off, I want to say, Steve Starr, there's been a lot of love for you in the chat, in the questions, people really appreciating you sharing your story. So the first question was to you, Steve. How long did it take you to actually recover from surgery itself?
Gosh, now you're asking me. So recovery from surgery wasn't too bad, actually. I actually thought it was going to be worse than what it was. Bizarrely, though, I will say one thing. One of the worst things I actually thought about, not the surgery. The surgery, I was out of hospital within the next day.
Yeah.
Literally out the next day. The one thing that I was actually more worried about was having the catheter removed. And that really freaked me out. That was in for 10 days, I think it was 2 weeks, sorry. After that, it literally was the incontinence I had to deal with to start with, the ED, the erectile dysfunction we know about. I think really from the actual operation, the prostatectomy, of having that done, I think within about 4 weeks, I was pretty much back to back to normal. I was mobile, put it that way. I then had to build up. From that point, I had to build up the length of exercise. So I used to enjoy running. Couldn't do that. I could go walking. I'd go down the end of the road, and all of a sudden I'd get there and go, "Oh no, I've got to come back again." And that just gradually built up over time. So it wasn't long, actually. Looking back on it, it wasn't actually that long.
I think you were off work for a couple of months, weren't you?
Yeah, I did take it. My work was very good. I mean, that's another thing people have got to think about as well, especially if you're self-employed. That was one thing I hadn't thought of. But on the online community, I was chatting to a few people. Some people were riding a bike within 6 weeks. Some people were running again within 4 weeks. For me, it was slightly longer. I was able to take time off of work, and I took 8 weeks off in total.
Okay. Yeah, the next question is for you again, Steve. So a lot of people have been saying how, they've tried various different things for their erectile dysfunction, various different treatments, and it's taken a long time with mixed results, to get anything successful. But they've been asking, what things did you try, pumps, Viagra, injections, etc. How successful were they, and how long did it take for them to become successful, if indeed they did?
No, that's a great question. So from day one, I was prescribed Cialis as a 5 milligram dose, and that was for penile health. That I took up until actually stopped probably about 3 months ago now, because it's not available on a prescription on the NHS. You actually have to buy it now. I cycled mine. I had Cialis again, but in a 20 milligram dose. And I had to cycle off of my normal 5 milligram, one for 48 hours, then take the tablet and then leave it for another 48 hours and go back onto my low dose. I personally didn't like it. It gave me a pounding headache. It felt like everything was going do, 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 and I didn't like it. It felt like my heart was rushing, and I thought, oh, I don't like this at all. And actually, it didn't even give me an erection. And I think that is probably partly what Isabel was saying. The psychological part of it was going, oh, I don't feel well. So it just didn't work. So then I didn't like the idea of the injection. To me, that was like, no, I'm not going anywhere near that. So actually I went with the pump in the end. And actually, to be fair, if I'm being really honest, it actually does work. I still don't get an erection like I used to before the operation, but it is very manageable. I would say something of that feeling or hardness, if you want to put it that way, of about 80%. Sometimes it works, sometimes it doesn't, and we actually laugh when it doesn't work. Sometimes we go, "Oh, I wasted all that time doing that." And you have to laugh about it. But that's how I went with the pump, and I still use that for penile health as well. Exactly what Isabel's saying. Um, I did. My penis did shrink, not dramatically, but enough that I noticed it. And the pump also helps bring that back and keeping the health there. So it's a real key thing.
Okay, thank you, Steve. And again, we really appreciate your honesty and your openness in answering some of these questions for us. So thank you. A question for you now, Isabel. So is there any guidance on how a couple can handle the double whammy to their sex lives where the man doesn't have erectile capacity following surgery and his partner's unfortunately going through menopause and loses interest in sex at the same time? Are there any techniques that can still allow a couple to be close and physical?
I mean, again, a lot of that will really depend on whether the couple are happy to try things that don't involve requiring a rigid penis. So, you know, from very early on, post-operatively, couples can engage in regular, what I call sensual or erotic behavior, what Steve and Stella referred to as playing around. And that playing around is absolutely crucial because if you leave a long gap from when you've had your surgery to when you feel perhaps more confident and ready to try and get an erection, it could be many weeks or many months before you feel like that. And in the meantime, you may find that actually you and your partner are feeling quite awkward about just there not being that kind of natural kind of emotional connection that's often brought about through sex and being physical and really close to each other. So a lot of couples will feel that there's a distance, if you like, between them. But you can actually engage in non-penetrative, non-coital, erotic sexual behavior from the very beginning. And that includes that even if you're not able to get an erection, one of the things which is I saw in the actual Q&A as well, is can you have an orgasm without having an erect penis? And the answer is yes, you can. So you obviously, most cancer treatments will mean that you will no longer be able to ejaculate. That's very common. But that doesn't mean that you can't experience a climax. And so men will be able to experience a climax with penile stimulation, even if the penis never becomes hard. So it's possible for a couple, like you've described, Jonathan, to actually engage in perhaps some mutual masturbation, for example, or to use vibrators together, or to use lubes that create a sensation. So you can buy lubes that cause either a warming, a cooling, or a tingling sensation where you apply them. So if you apply them to the clitoris or the vaginal entrance, or if you apply them to the penis or the tip of the penis, you'll get those sensations. And that helps you focus in on the sensations that are happening in that part of your body and really helps you kind of concentrate in on being erotic and being sexual together. Even if you've got a lady who's either already gone through the menopause or who's beginning to go through the menopause, where her sexual desire may be going lower at the same time, as you say, as the partner has gone through surgery and is feeling less sexually confident, the way to keep the couple erotic communication together is to do that gentle sexual exploration and playing together, but without the expectation that penetration has to happen or that an erection is part of that. And by taking that pressure off themselves, they can actually then relax and enjoy the other elements of their sexual response. So they're then encouraging their desire to come back gradually. They're actually encouraging relaxation. They're also encouraging couple communication. What's working, what's not working for me? How is that feeling? But without the pressure of having to get an erection, having to keep an erection, and having to try and have penetration. And then with regards to the lady, depending on her own circumstances, if she's experiencing some vaginal dryness or discomfort as a consequence of going through reduction in her estrogen levels, then I would definitely be advocating her to try a vaginal moisturizer and vaginal lubricants to actually help with that side of her sexual well-being. So she's looking after her vaginal health and he's looking after his penile health.
Great. Thank you, Isabel.
All part of that process.
I think there's another question here which I think touches on that, so it'd be a good time to maybe talk about that now in a similar vein. It's somebody who's had a prostatectomy. They find that if and when they masturbate, that a dry orgasm is actually unpleasant, and the
Right.
pumping is over intense and even painful. So they're tending to give up halfway through because it's just effectively not worth it, or it's causing too much discomfort. Do you have any comments or advice that you could give in that kind of a situation?
Yeah, I mean, it may be, instead of using the pump, if for example, and again, I'm filling in gaps here, but if, for example, the erection is being created by the pump, and then that erect penis is being masturbated, and that is quite intense and quite uncomfortable, what I'd suggest is maybe trying to actually masturbate and stimulate the penis without it being erect, and seeing what sensation that creates. Typically, there are often periods of time, especially soon after surgery, where the orgasm certainly feels different. The dry orgasm feels different. But if you avoid climaxing, then the next time you climax, it's more likely to be intense, because you've created sexual tension, but you've not created a release for it if you actually stimulate the penis. So I know it sounds counterintuitive, but regular gentle stimulation of the penis, particularly if it's still soft rather than hard, and allowing a gentle orgasm to come is better than having perhaps longer periods of time between climaxes, which is likely to make the feeling of the orgasm more intense, if that makes sense. The other thing that you can do is that you can do what we refer to as a sort of like a wax and wane approach, which is where you gradually stimulate the penis through masturbation up to the point where you're beginning to feel like an orgasm is going to happen. And then you'd gradually let it fade again. And you just do that, coming towards it and letting it go. And in a way, what you're doing is you're helping teach the body that natural stimulation and movement, but you're not making it get to full orgasm straight away. So you're practicing almost like a number of kind of, gentle runs towards it. And by doing that and having that regular stimulation, you then get to the point where you can actually then try that orgasm fully. If the pain persists, it's definitely worthwhile speaking to your urologist or andrologist at the hospital, because it may indicate that there may be a narrowing in the urethra, which might be causing difficulty. So it's always worthwhile mentioning it. And there are some medications that can be given to help with orgasmic pain, but that's usually best discussed with your urologist or andrologist.
Great, thank you. Right, Lisa, I know we've not come to you yet in the Q&A session, but there's one for you here. So is there a way of handling climacturia for somebody after a radical prostatectomy without going for further surgery?
Yes, so thanks for that, Jonathan. Thank you for the question. We do actually get asked that quite a lot on the specialist nurse service. So climacturia is actually leaking urine during orgasm or during sex. Okay, firstly, it's completely normal. It's bodily fluid. It's not dirty. And it is something that happens quite regularly for men after they've had their prostate removed. There's a few different things. So you can use a condom, you can put towels down, you can have sex in the shower. You can also empty your bladder beforehand. Sometimes that can be really beneficial if you've got an empty bladder to begin with. Also try to avoid drinking beforehand as well. So it takes around 3 hours from when you drink it to when it goes into the bladder and you need to pee it. So if you kind of work backwards, then you could refrain from drinking roughly 3 hours before. I appreciate it takes the spontaneity away a little bit, but the more you get into that habit, it may help. Also, there's some other things that you can do. So, for example, pelvic floor exercises. As nurses, we harp on about this all of the time. So pelvic floor exercises basically strengthen the muscle that surrounds the urethra, the water pipe, the bladder, and where the prostate was, and also the bowel. and it's a support mechanism. Okay, so if you have a good pelvic floor muscle, then that should help with the leakage. If you want to know more about pelvic floor exercises, you can always call us, or you can put it into the search on our website, and then there's a fact sheet that you can download. Also, you can use a penile tension ring, which Isabel mentioned earlier. That's also, she's waving one around right now, which is a bit odd, but thank you, Isabel.
Sorry, just thought I'd put the prop in there, Lisa, for you.
So it's also known as a cock ring.
Yeah.
Also, if you've got vacuum device, so most men who've had surgery will have a vacuum device. The vacuum devices come with them. You can always use one of those without using the vacuum device if you want. So there are a few different ways. Of course, you can always give us a call if you're worried about anything, and we can go over that with you. Thanks, Jonathan.
Okay, thank you, Lisa. And then next one is also for you. So this is somebody who has erectile dysfunction 2 years after bilateral nerve sparing radical prostatectomy. And they're asking, is there any hope for nerve improvement in the future?
Okay, so short answer, yes, there is a possibility. So when the surgeon removes the prostate, round the back of the prostate, there are bundles of nerves. And it's those nerves that I was talking about earlier, which go from the brain to the penis. That is the pathway. Usually with surgery, they can either do bilateral sparing, so they can keep both sets of nerves. They can remove one, or they can take all of them, depending on where the cancer is situated. And that's a really good question to ask your surgeon beforehand and also afterwards to check if they're able to leave the nerves or not. Now, if those nerves are preserved, they are still rummaged with. Okay. Now, as I said, I do like my analogies. The nerves are a little bit like a cobweb. Okay. So when the surgeon is removing the prostate, he has to peel the cobweb, those nerves, away from the prostate if he's trying to keep them. So if you imagine picking up a cobweb and moving it to another area, the cobweb won't ever look the same again. Some of the strands will get broken, and that is exactly the same. So even if the surgeon has left those nerves, they can get damaged, they can be a bit frail, a bit fragile, a bit battered and bruised. So what lots of surgeons do nowadays is they talk about penile rehabilitation, and that's a two-pronged approach. So and this will feed into another question that we've actually been asked as well. So the two-pronged approach is using a PDE5 inhibitor, so for example Cialis or Viagra, and then also using a vacuum device daily for about 10 minutes a day. And that mimics those nighttime erections that I mentioned about. So that keeps the blood circulating. It's a little bit like a penile gym, if you like. And if you think back to the plaster cast, when you've broken your arm, the plaster cast comes off, you go and have physiotherapy to learn how to use that arm again. Everything needs to be sort of positioned. It needs to have the physio to get working. Exactly the same with the penis. So the vacuum device is like a gym. It's your physiotherapy. And using that, forcibly getting blood drawn into the penis keeps the penis in good condition. It will reverse penile shrinkage. It will get the penile tissue looking healthy again. And you may find that it looks better, shape, colour. It should hopefully get back to pre-op as well. Now, with regards to how long after treatment, this is where it gets a little bit complicated. Unfortunately, there haven't been many clinical trials looking at this, and therefore there's little clinical evidence around it. It also is based on clinical experience, so doctors' experience, nurses' experience. Okay, there have been a few papers written on it. So a paper from Melissa Hadley Barrett, she said that it can take between 2 and 4 years post-prostatectomy for the nerves to heal. Other papers said it can be up to 4 years, and others suggest maybe 18 months. So you can see it's a very big, vast time difference from 18 months all the way to 4 years. So yes, 2 years on, it is still possible. The longer you leave it, yes, it can make things a little bit trickier, but it's not impossible. The saying, if you don't use it, you lose it, is very true in this scenario, unfortunately. So using the vacuum device for your exercises is really key to keeping that blood circulating, getting that penis in good health. And that will also then have a knock-on effect for any other treatments that you decide to go down in the future. If you've got a healthy penis, all the other treatments will help more effectively. Sorry,
Thanks.
Jonathan.
No, it's okay.
You're
Thanks,
rabbiting
Lisa.
on.
No, not at all. I've just been prompted by the nurses in the background just to reiterate that a lot of some of the questions have been answered in the Q&A section. So if you're looking for an answer to your question, just check in there to see whether they've been able to answer the question in the chat. But my next question then, and this is potentially to both you, Lisa, and Isabel, is that someone has asked, will using a vacuum pump help to bring back what they're calling a normal erection or a pre-operation erection, or are they resigned to using a pump every time in the future?
So, oh, sorry, Isabel, do you want to
No,
go
you
first?
go on. No, you go on. You go first. You go first.
So I was going to say exactly very similar to what I've said before. Unfortunately, there isn't a lot of clinical data out there to say how long you should be using it for. So usually penile rehabilitation consists of the PDE5 inhibitors, so the tablets, alongside the vacuum device. So therefore, potentially 18 months to 4 years if you go by the evidence that is out there. I would always sort of suggest that using it daily until you get some form of an erection, be it with spontaneous or with medication, as long as your penis is getting that regular erection, therefore then it's going to be healthy. Some men find that they can drop down to once every couple of days, then once a week, once a month. But as long as that penis is getting the blood circulating, doesn't really matter how, as long as it keeps it healthy. Isabel, do you want to add anything to that?
Yeah, I mean, I think Lisa's very right in what she's saying in terms of it's difficult to be absolutely definitive, even though I know people want concrete answers. I think one of the things to say is that the more proactive people are, which is really what Lisa's saying, the more proactive people are at penile rehabilitation strategies, the greater they're giving themselves the chance for maximum recovery, as it were. But actually, I think most of the published research around sexual function after prostate treatment, not just surgery, but after radiotherapy as well, would certainly indicate that nobody goes back to it being identical to their preoperative state or their pre-diagnosis state. There is always the need for some additional consideration. So it's very rare to go back to exactly the way the function was beforehand. And I think it's also really, really important to bear in mind that it's not just prostate cancer and prostate treatments that cause erection changes. It's very much thinking about what were your own erectile circumstances before your diagnosis and your treatment actually happened. So if individuals, for example, are overweight, if individuals have got other conditions such as the ones that Lisa mentioned previously in terms of heart problems, blood pressure problems, diabetes, etc. One of the single most important factors of determining post-treatment recovery is pre-treatment function. And that's not just thinking about it from a physical point of view, but also from a mental or emotional point of view. So again, going back to what Jonathan was emphasizing, it's not just how healthy you are physically and how much you're doing your penile rehabilitation, which of course is really important, but it's also how healthy are things from a psychological perspective, and also how supportive is the relationship context within which you're actually trying to be functional as well. So it's those three key components: what's happening physically, what's happening emotionally, what's happening in the relationship. All of those things are important as an approach to actually maximize what your recovery is likely to be.
Thank you, Isabel. There is one more question potentially that the nurses in the background are just going to serve up to me. They say it'd be a good question to ask. I can't see it right now, so I'm just going to wait for a few seconds to see whether it gets delivered to me or not. If it doesn't, we'll end it there. Okay, I have it here now. So it says, oh, and it's got lots of drug pronunciation, so I'm going to struggle with this pronunciation. Apologies for that. So how long after completing a course of Decepticil? We'll go with
Decapeptyl.
Decapeptyl.
I'm glad you
Yeah.
know. Injections should libido return. This is distinct from erectile dysfunction, which can be helped, such as with Viagra. Does that make sense?
Yeah, that makes
Sorry,
perfect
I'm
sense.
reading it I'm trying to understand it as
Yeah.
I'm reading it.
Yeah. So that drug, the other name for it is triptorelin. So it's one of the androgen deprivation injections like Zoladex, etc. So you're given those injections in order to suppress testosterone by suppressing things at the pituitary level. So actually making sure that the body isn't producing any testosterone at all. After you stop those injections, obviously you've got the initial period of, well, how long do those injections work for? Whether they work for a month or they work for 3 months, you've then got to wait at least that month or that 3 months before the activity of that drug is actually completely out of your system. So that's the initial time period. And then in addition, it really does actually depend on your age. So if you're a younger gentleman, and you're coming off androgen deprivation therapy completely, then your testosterone level can take up to 12 months to get back into the normal range again. It's worthwhile asking your urologist or your clinical oncologist to test your testosterone, or your GP to actually do a testosterone level to see if it's come back up into the normal range, because that will then give you a feel for not only actually maybe a return in some of your erections, again, depending on the treatment that you've had, or it will also mean that you'll begin to actually find some sexual feelings beginning to come back. But it's important to recognize that if you're an older gentleman, the older you are, the longer it's likely to take for recovery from having all of your testosterone suppressed to it coming back up into the normal range. Still important to ask again to have that checked intermittently, maybe, you know, once every 6 months, couple of times a year, to actually have that information in your head so that you know what's happening. Bearing in mind, however, of course, that no one tends to have their testosterone measured prior to starting treatment. That's not usually part of the pathway. So we don't know what your testosterone was doing prior to you having your treatment. And as you get older, by decade by decade, your testosterone level tends to drop anyway. So the older you are at the time of diagnosis, the greater likelihood that your testosterone in the normal range would be towards the bottom end of it. And therefore, again, the longer it might take for it to come back into the normal range once you've actually come off that. So I would certainly say, you know, up to 12 months is very common. And in a tiny percentage of men, some studies have indicated about 10%, it may not recover at all. And in that instance, then it's about speaking to your treatment team to find out if there's anything they can recommend that might actually help those circumstances. I don't know if you want to add anything, Lisa.
No, I think you've covered it really well. Thanks, Isabel.
Thanks, Lisa.
Okay, so we're almost out of time for this evening. But before we go, I just wanted to bring up one more poll. So hopefully that will be appearing on your screen right now, for us to just get some feedback on how useful you found this evening. So yeah, how would you rate this webinar this evening? And those are your options there. So as before, I'll leave this open for a little while just to make sure everybody's capturing the responses that they want. So 120 of you still here, so just open it, keep it open for a little bit longer. Okay, I'll end it there. Thank you very much. Okay, so yeah, I just wanted to say, well, I was going to say a big thank you to our panelists, but what I can actually do instead is I can go one better, because rather than me saying thank you to everybody, we've had this feedback through in the Q&A section, so I wanted to read it out. So it says, before finishing, can you thank your speakers for me? It's the first time I've had honest answers to the questions posed and really good guidance here. Very much left to ourselves here in Scotland. Brilliant session, and the panel are very informative and have helped significantly. So that's far better thank you than I could possibly give. But what I will do is I would like to just give a shout out to the nurses and the health information team that are working in the background, making sure that all the slides are where they need to be. The links have been served up. So big thank you. We couldn't have done this without you. So now, just to wrap things up, if you could keep an eye on your email inbox over the next few days, we'll be sharing a survey to ask you in a little bit more detail what you found useful, how we can improve and shape our information and support in the future. There'll also be a link to the recording of this webinar. We'll be putting that up on YouTube and also on the website, and we will also be circulating the questions that we were unable to answer. Isabel, I can see your hand is up. Is there something you would like to add?
Yeah,
Please go ahead.
It's something that Jonathan and Lisa and I were talking about when we were doing the prep for today. But because it's a Scottish, I'm imagining a Scottish person or someone living in Scotland is saying what they've just said. And me being based in Edinburgh, I can't resist kind of responding on the Scottish context. So what I would say to the lovely person who said that was, number one, of course, please access Prostate Cancer UK, because they are your UK-wide service. So whether you're based in Scotland, Wales, Northern Ireland or England, PC UK is there for you. So that's number one. Secondly, there is a specific charity based in Scotland called Prostate Scotland, and they offer a course called Living Well After Prostate Cancer, and that's being run through a range of different Maggie centres. So a lot of the Scottish-based Maggie centres are actually offering an online. So if you don't live near a Maggie centre, you can actually still access, by contacting the Maggie centre that you're closest to, you can still access those courses that are run jointly by Maggie's and Prostate Scotland. So don't be a stranger. There is stuff around in Scotland. It's just perhaps not as well networked and perhaps as high profile as a lot that's happening elsewhere in the UK. But I just felt I needed to say that. Thank you, Jonathan.
No worries at all. Thank you. So, well, I'm probably repeating myself slightly here, but don't forget there's a wealth of prostate cancer information on our website, and our specialist nurses are available Monday to Friday, 9 to 5 on 0800 074 8383. Please keep your eyes peeled for more webinars as well in the future. We'll be sending out invites via email once they have been finalised. So I just wanted to say thank you. Have a good evening, everyone, and take care.